Hello, everyone. My name is Tom Gong. I'm from Wuhan United. We are based in San Jose. We are a nonprofit organization. We focus on providing a platform to enable doctors from around the world to exchange information so that doctors can fight coronavirus together. Let me share my screen. So today is April 4th. The topic of today's seminar is care of pediatric patients during COVID-19 pandemic. We're very happy to have professors from doctors from Wuhan Union Hospital, Tongji Medical College, Huazhong University of Science and Technology. Wuhan Union Hospital was founded in 1866. It's the largest and also the oldest Western-style hospital in Wuhan. It has 5,000 beds and 8,000 staffs. We have 3 speakers from Wuhan Union Hospital Pediatric Department. First speaker is Dr. Ruiming Jin. He's chairman of Pediatric Department. He has been doing research and clinical work in the blood and tumor of children for many years. The second speaker from Wuhan Union Hospital is Dr. Xiaoyan Wu. Her specialty is also tumor and children's genetics. She's an associate professor and vice chair of pediatric department. She has been doing research in the United States several times at Houston Methodist Hospital and also a research institute in Maryland. The third speaker from Wuhan is Dr. Lei Li. She's an associate professor and vice chair of pediatric department. She has done postdoc research in Maine Medical Center in the United States. Her specialties are pediatric intensive care and also hematology. We're also happy to have 2 doctors from the United States to help host the seminar. Minghua He, she's the partner and owner of 40 Conservage PC in Pennsylvania, United States. She's a fellow of American Academy of Pediatrics. The second host is Dr. Julia Zhu from San Jose, California. She's a family medicine doctor. She's with Stanford Healthcare. We also like to thank Mead Johnson Nutrition very much. Mead Johnson Nutrition helped us to invite a lot of doctors from United States and around the world to attend today's seminar. Thank you very much, Mead Johnson Nutrition. So let me, Dr. He, take over the podium, okay?
So today I will introduce the diagnosis, treatment, and the prevention of COVID-19 in children first. Then I will briefly introduce my flowchart to manage the pediatric leukemia patients during this pandemic. Firstly, let me show you the data from Chinese CDC and also some data from publication. Here is the information in China. From January 16 to February 5, 2020, there were 2143 pediatric patients with COVID-19 reported to Chinese CDC. For this population, there were 731 laboratory positive cases and 1412 suspected cases. And 13 cases account for 56.6% were boys, and there was no significant difference for gender. The age of disease of this onset ranged from 1.5 months to 17 years. And from onset to diagnosis, the median time was 2 days, range 0 to 42 days. Also, of the 2143 pediatric patients, only 1 child died. Of this population, severe and critical cases account for 5.9% or much fewer than adults, because since adults is account for 18.5%, and most cases are male. Until now, the knowledge we have obtained is the first one: children at all ages appear susceptible to COVID-19. And over 90% of all patients are symptomatic, mild, or moderate cases. Compared to adults, the incidence in children was much lower, and also compared with adult patients, clinical manifestations of children was less severe, and the case fatality, mortality rate was much lower. And most of them have a close contact with infected cases or family cluster cases. That's very important point for children. It's also totally different from adults. Young children, particularly children less than 3 years old, accounted for majority cases, and the critical cases lies in this age group, which means this group demanded extra attention during home care and hospitalization. That's for the information. This population from our group. This population this data was from multiple centers in China and the labor area in Hubei province. And also this study was organized and coordinated by Dr. Jin Yunli. This study shows us the clinical characteristic of pediatric COVID-19. Based on the guideline with the seventh edition issued by National Health Committee and some other published strategy, I'd like to talk the following points. First, I will share the clinical features, laboratory examinations, chest imaging, and also I will talk diagnosis. I will talk suspected cases, confirmed cases, classification of confirmed cases, and how to early identification of critical cases. Then I will talk treatment and release and discharge criteria. Lastly, I will talk prevention. First, the critical features, laboratory examination and chest imaging. First of all, what was the presenting clinical characteristic of COVID-19 in children? I think most of clinicians are concerned, this is the much concerned point. Clinical characteristics, based on the current epidemiological survey, the COVID-19 has a latent period of 1 to 14 days, mostly ranging from 3 to 7 days. And also most infected children have mild clinical manifestation. They might appear just a fever or dry cough or fatigue. This is the top 3 symptoms. Someone will ask this point. The top 3 symptoms is the fever, dry cough, and the fatigue. Some patients presented upper respiratory symptoms like a nasal congestion and running nose. Some patients presented maybe gastrointestinal symptoms like abdominal pain, nausea, vomiting, and diarrhea. Maybe they have no fever or symptoms of pneumonia, and they will have a good prognosis. Most of them recover within 1 to 2 weeks after onset. Some patients might appear asymptomatic. This is very important point. And even though clinical symptoms in pediatric patients are milder compared with adults, but still few may progress to severe cases, usually 1 week after onset. Some children have dyspnea, which can rapidly progress to acute respiratory distress syndrome, ARDS, septic shock, metabolic acidosis, coagulations, dysfunction, and multiple organ failure. Till now, in the information from CDC, one death in children with underlying disease have been reported till now. So the potential risk of death should be highlighted. And also we have noticed one issue, that is no intrauterine infection cases have been reported yet. But newborn can be infected by exposure. That means close contact still can induce the newborn infection. Next, we'll talk what's the laboratory finding in the pediatric patients. I think this part will be referred to the point that maybe you are wondering which person I should send to office. So when the person presented the clinical characteristics above, you should send the person to office. And what the laboratory examination you should order. First, in the pediatric patients, CBC, white blood cell count, CBC, complete blood count should be ordered. And also the patients present white blood cell count is normal or decreased. And with decreased lymphocyte count. And also, if you order the liver enzyme, muscle enzyme, and the male hemoglobin levels may be increased in some patients. But pay attention, please pay attention here. CBC is not applicable for the leukemia patients with COVID-19. Since I'm a pediatric hematologist, so I called attention for this point. CBC is not applicable for differentiation diagnosis of COVID-19 in leukemia patients. And also, most pediatric patients display elevated CRP level, EST, and or normal PCT. And severe cases might show high D-dimer levels and progressively decrease the blood lymphocyte counts. Other pathogens, common respiratory pathogens are detected if necessary. And also samples from nasal, pharyngeal swab, sputum, BAF, nano swab are tested for nucleic acid RNA test. Serums are tested for antibody. And also, furthermore, I think you should order the chest imaging. Chest imaging include chest X-ray or CT scan. Actually, compared with adults, the lesion in pediatric patient is smaller and is easy to be missing in the X-ray. So maybe no abnormal findings are found in the early stage of disease in children. I will say X-ray just is not suitable for examination in pediatric patients in the early stage. X-ray maybe can be used for re-examination and comparison in patients to the previous lesion. Suspected cases or confirmed cases should take the chest CT scan as soon as possible. In the early stage of disease, chest images show multiple small plaque and interstitial changes, which are observed in the lung periphery. Further deteriorate to bilateral multiple ground glass opacity and or infiltration shadows. Lung consolidation may occur in severe cases. Pleural effusion is rarely seen. Now we have talked clinical characteristics and laboratory examination, chest imaging examination. Then what's the diagnosis? Firstly, how to identify the suspected cases? I think this question is the which one you will send to test the RNA kit. I will say the patients who meet any one of the any one of the criteria in the epidemiological history and any two of the criteria in clinical manifestation. Here I want to talk more about the epidemiological history because it's very important. Maybe you can refer to the children with a travel or residence history in epidemic area within 14 days prior to onset. Also, children with contacting patients with fever or respiratory symptoms from epidemic areas within 14 days prior to onset. All children who are related with a cluster outbreak or close contact with COVID-19 infected cases. Also, you have to pay attention to newborns delivered by confirmed COVID-19 infected mothers. Any one of these epidemiological history and any two of the clinical manifestation. Clinical manifestation, I want to talk more. How to identify the confirmed cases? I will say the suspected cases with meet any one of the following criteria. Well, I will say is he is the confirmed cases. Respiratory tract or blood samples tested positive for the RNA RT-PCR, or genetic sequencing, or specific antibody, IgM and IgG are positive. If this is if the antibody detection is available, depends on the stature. For the confirmed cases, we also classify the cases into 5 groups. This is very important because it will the treatment, it depends on this classification. First type is a symptomatic infection. Then the second type is acute upper respiratory tract infection. The children present only fever, cough, pharyngeal pain, nasal congestion, fatigue, headache, or myalgia or discomfortable or without sign of pneumonia. This we said this is acute respiratory upper respiratory tract infection. How to identify the mild pneumonia? Refer to the children with or without fever, respiratory symptoms such as cough and chest imaging indicating pneumonia, but not reaching the criteria of severe pneumonia. The next type is severe pneumonia. I think here it is important for you because by my knowledge, United States maybe the above the three types, for the above the three types, government encourage the patients just stay at home, so isolated by themselves. But if we refer to the severe pneumonia patients and the critical patients cases, you have to identify them and send them to the hospital, even to the ICU. So how to identify the severe pneumonia? I don't want to read out one by one. I just put the slide here. And also we have, also we have the criteria for the critical cases. So how to tell the population with high risk? According to the experienced, children with a history of contact with severe COVID-19 cases or with underlying conditions such as the congenital heart disease, bronchial pulmonary hyperplasia, or respiratory tract abnormality, normally with abnormal hemoglobin level, severe malnutrition, or with some immune deficiency cases or immunocompromised status, such as the long-term use of immunosuppressants. For such population, we should pay attention to double check if they meet any one of the criteria and may become severe cases. How to early identify the critical cases? This is also important for you, I think, because maybe you have heard in China, some patients, just as a sudden, some patients from the mild, from the severe condition, just suddenly transfer to the critical condition. So how to identify this status is very important for you. I also list some points here. I don't want to read out one by one. Short period. Infants younger than 3 months, extramedullary complications, co-infection with other viruses and or bacteria, significantly increase the D-dimer and the cytokines interleukin-6 and interleukin-10. The last point, the last one, I would say it needs further discussion. Differential diagnosis. I don't want to talk more. We've already discussed it. Differential diagnosis should be made to distinguished from the common respiratory pathogens like influenza virus, adenovirus, respiratory syncytial virus, Mycoplasma pneumonians. And I have to mention the co-infection of COVID-19 with other viruses or bacteria, even fungus should be considered in diagnosis. Treatment. For the treatment, based on their medical conditions, suspected patients should be isolated in a single room or self-isolated at home following the doctor's advice. Confirmed cases can be admitted and could be arranged in the same ward. Critically cases should be admitted to ICU as soon as possible. For the general treatment strategies include bed rest and supportive treatment, ensuring sufficient calorie and water intake, maintaining water electrolyte balance, and homeostasis, monitoring vital signs and oxygen saturation. This is very important, oxygen saturation, and keeping respiratory tract unobstructed and inhaling oxygen when necessary. Measuring blood routine, urine routine, CRP, and other blood biochemical indexes, including liver and kidney function, myocardial enzyme spectrum, and coagulation function according to patient's conditions. Blood gas analysis and timely re-examination of chest imaging should be performed if necessary. Symptomatic treatment. The patient with a high fever should be activated controlled. If body temperature exceeds 38.5 centigrade with discomfort, we will provide physical cooling or antipyretic drug. Common drugs include acetaminophen by oral, 10 to 15 milligram per kilogram is recommended dosage for each time. Keep children quiet and administrate sedative immediately when convulsions or seizures occur. Oxygen therapy. I said this is a very important procedure. When hypoxia appears, effective oxygen therapy should be given immediately. Oxygen therapy includes 3 levels. The first level is nasal catheter, master oxygen. The second level is high flow oxygen therapy, and NIV, non-invasive ventilation. The third level is invasive medical ventilation. I mean IPPV. That means intermittent positive pressure ventilation, IPPV. Usually, we need a level up of oxygen strategy when hypoxia cannot be alleviated. Please pay attention here. We don't wait much time, and usually level up the strategy ahead of schedule. Antivirus therapy. We could try antivirus drugs for all 5 types of confirmed cases. That's in my opinion. Antivirus drug, we always use the interferon alpha. Interferon alpha can reduce the viral load in the early stage of infection, which can help to alleviate symptoms. That's by the publication. and it might shorten the course of disease. The recommended usage is the acetylcholine. I don't want to read through. And also we use the interferon alpha nebulization, interferon alpha to beta spray. Nopilevir, letrozole has been tried to used for the adults with COVID-19, but its efficacy and safety is still unclear for the children. Antibiotics, we need avoiding irrational use of antibiotics, especially in combination with broad spectrum antibiotics. Need paying close attention to the changes of conditions in children with co-infection of bacteria or fungi infection. Need actively collecting samples for pathogen analysis and timely or rational use of the antibiotics or antifungal drugs. Abidol, oseltamivir and other anti-fluvial drugs. Abidol is administered for adults infected with COVID-19. However, its efficacy and safety remain unclear. Oseltamivir and other anti-fluvial agents can be applied for patients co-infected with other influenza virus. Other drugs like glucocorticoids, the use of glucocorticoids should be based on the severity of symptomatic inflammatory response, degree of dyspnea, or with or without ARDS, the progress status of chest imaging results. Glucocorticoid can be used in a short period, 3 to 5 days. The recommended dosage of mezproidsonol should not exceed 1 to 2 milligrams per kilogram per day. Immunoglobulin can be used in severe cases when indicated, but its efficacy needs further evaluation. What's the release and discharge criteria? For the confirmed patients, they can be discharged from isolation or transferred to the corresponding departments for treatment of other disease if all the following criteria are met. First, the body temperature returns to normal longer than 3 days. The respiratory symptoms improve obviously. The detection of respiratory pathogenic nucleic acid is selective for 2 consecutive times. The sampling interval is at least 24 hours. For the suspected patients, can be discharged from isolation when the detection of respiratory pathogenic nucleic acid is selective for 2 times. The sampling interval is still with 1 day, 24 hours. Prevention. The novel coronavirus infection is a new communicable disease with an emergent outbreak that affects all population global-wide. COVID-19 has been classified as a Category B infectious disease legally, but managed as a Category A infectious disease. It's paramount to complement infection control practice by infection source controlling, transmission route blocking, and susceptible population protecting. I don't want to talk more here. That's the first part. I talked the diagnosis, treatment, and prevention of pediatric COVID-19. Now let's move to my second topic. Management of wards of pediatric hematological malignancy during COVID-19. Since the time is limited, I just have to briefly and quickly go through them. Firstly, let me describe the challenges for us at that time. As you know, coronavirus pandemic happened in Wuhan at the beginning stage and spread out worldwide very soon. At that time, the Wuhan government transformed almost all the hospital for treatment of COVID-19 patients. Majority departments in the hospital were almost transformed. Hospitals were opened for COVID-19 patients and staff were assigned to isolation wards one by one in patched, which means a shortage of trained nurses and doctors severely weighed on the support of the leukemia patients provided by us. Meanwhile, shortage of protective material, protective equipment, and the limitation of the test kits at the initial stage, they were a big problem for us. That means we won't test the antibody, we won't test anybody as we want. We had to choose out strong candidate, choose out strong suspected cases for RNA test. But on the other hand, leukemia patients have been drained out of hospital and waiting on the long list for admission for chemotherapy. We had a clear idea that interruption of chemo might come into poor prognosis on them. So even though we were in such a situation, we still think we should take up our responsibility for these patients. We established the management guideline and successfully went through the hard time. This is the publication from our team, which is the management guideline for pediatric cancer wards during the pandemic. Fortunately, we have no one missed diagnosis of patients and guardians, and we hadn't anyone nosocomial infection in the wards as well. Right now, I would like to share our experience from the following 2 points. I will talk a flowchart strategy for pre-admission management and the management of wards.
吴医生，你那个白板要清一下，你有上面有个线 ，whiteboard， 你那个你要 ，yeah。
Sorry, let's continue. A flowchart strategy for pre-admission management. Today, you might have found the flowchart style as well, but by my knowledge, we have never seen any flowchart at that time. We designed the flowchart to screen the children with cancer and the guidance for COVID-19 step by step. For the children with leukemia, each one would be surveyed epidemiological history. For the children in Wuhan, in Hubei, we assumed that each patient had the epidemiological history positive. After the survey of epidemiological history, we go ahead to check the symptoms for the patients. For the children without epidemiological history and without symptoms, we would get chemo on schedule. For the children have epidemiological history, well, whatever they present symptoms or not, we would postpone the We postponed the chemo and ordered the examinations for them, including CBC, CRP, chest CT, or respiratory pathogens if necessary. If the patient meets the criteria of success, suspected case, expert consultant and RNA test would be required. Currently, with the control of infection and the sufficient supply of the test kits of RNA and antibody, right now, we would order 3+3 examinations, which means we would order RNA test, antibody test, and chest CT for either patient or the guardians, on caregiving. Evaluation tests, we've talked, I just skipped this one. How to evaluate for success the cases we have learned already. Other consideration, sample contaction. Nasopharyngeal swab is recommended for higher sensitivity and compliance compared to throat swab. Considering this cooperation is high risk of exposure to virus, level 3 protection should be provided for the collectors. What's the level 3 protection? Dr. Lee will introduce it later. As a consideration, guardians. For guardians or caregiving, CBC, chest CT scan, COVID-19 nucleic acid test, COVID-19 antibody test should be ordered. So we talked the flow chart for pre-admission stage. Now, how to management of the ward. We need to formulate the symptoms of the ward during the pandemic, prevention and control infection systems, consultant systems for new suspected cases, admission process and requirement for patients and guardians, prompt response for new suspected or confirmed children in the ward. This is the system. For patients, 1 patient, 1 room. At the first 5 days in the ward, the patient was settled in the buffer ward. 5 days later, the patient didn't present any symptoms and complete second viral test, then he would be transferred to a treatment room. Buffer room, treatment room, buffer ward, treatment ward, just a different area separately. Buffer area looks like half clean area. Support and psychological intervention by volunteer consultants, social workers, if needed, also is needed. For guardians, here it means the management of guardians in the ward. Previously, we talked the management guardian in the pre-admission stage. Here is the ward management. For staff, firstly, they need to get training. Then different protection levels provided for different area. Dr. Lee would talk more details for this point. This part is important. Prompt response for new suspected or confirmed children in the ward. I want to talk more. When new suspected case emerge out in the ward, what shall we do? In case of suspected case in the ward, the chemo should be suspended immediately. Effective isolation and treatment should be taken for the patient. Report to the hospital manager, requires the committee for consultant, and requires the nucleic acid test. Once the diagnosis is confirmed, the special vehicle shall be used to transfer to the designated hospital for treatment according to the standard requirement. Okay, that's all my presentation. I want to say due to the no incidence of COVID-19 in children and no incidence of COVID-19 in children with cancer, but by our knowledge, close contact in the family is the high risk of exposure to coronavirus in children. So management of pre-admission stage and management of the ward is very, very important. That's all. Thank you. Thank you, everyone.
Thanks, Dr. Wu, for a great talk. Next, let me welcome Dr. Lei Li. Dr. Li will also focus on two topics tonight. The first topic is protection for medical staff, and the second topic is the management of children with other non-COVID-19 related healthcare needs. Dr. Li, please take it over.
Thank you for the introduction. So hello everyone, my name is Lei Li from Department of Pediatric Union Hospital from Wuhan. So it's my pleasure to be here and share our experience in COVID-19. So my topic includes two topics. One is protection for medical staff. So I think when we do our duty to take care of our patients, especially children, make sure the first thing is protect ourselves first. So we can look at the workflow management. So I think the first thing, when we do some work in a fever clinic and isolation ward, everyone must have a training, strict training and examination to make sure everyone can know how to put on and remove personal protective equipment. That's very, very important. And then we should have enough relax. So each person should limited to a maximum of 4 hours of working in an isolation ward. And as the third one, we should arrangement our clinical treatment and examination or disinfection for our team. So can reduce the frequency of staff moving in and out of the isolation ward. And the fourth one, when we finish our work, we must wash ourselves and conduct the necessary personal hygiene regimen to protect possible infection of our respiratory tracts and mucosa. So after we come back to finish our work for a whole day, so we in our hospital, our staff couldn't go back to their house and couldn't stay with their family members because it's some potential to bring some dangerous virus to our family member. So our hospital will offer our staff, especially the frontline staff, have a hotel room. So each one have one hotel room to stay and can work from work and relax in the room. So that's very important. So if you work at the frontline isolation area, so you make sure just live in an isolated room. Don't contact with your family member. So the second one is you don't want to lose our weight, just have a nutritious diet that can improve our immunity. The third one is monitor and record the health status of all staff on the work, on the job. And if someone have a fever or any other symptoms, you must report to our department leader or hospital leader, and then make sure you have a good mood and make you have a very good level of physiological and psychological stature. The fourth one, if the staff have any relevant symptoms such as fever, you must be isolated immediately and to do some tests of the COVID-19, such as NAT or antibody testing. The fifth one, usually when our staff work at the front line for 2 to 3 weeks, they will relax or isolate in isolation area for 14 days. And before they come back to the work area, they will have a test for NAT and antibody and CT scan in lungs, just make sure they didn't have infection of the COVID-19. So this protection level is very good for everyone, especially for during with the confirmed patient or suspected patient. So the management including 3 levels, level 1, 2, 3. So level 1 is just the basic level of the protective equipment, including disposable surgical cap, surgical mask, work uniform, and latex gloves, and the isolation clothing if necessary. That's level 1 used in pre-examination triage, general outpatient department. Level 2, you can see the mask changed to medical protective mask, N95, and maybe with goggles. So level 2 is used in fever outpatient department and ICU, and non-respiratory specimen examination of a suspected or confirmed patient. You can see level 2, our staff may be work close to the suspected or confirmed patient. So you should remember where put on the medical protective mask, N95. Level 3 protection, except above the equipment, we should put on full-face respiratory protective devices, because the staff will do some dangerous operations, such as tracheal intubation, and do some surgery, autopsy, and carry out NAT for COVID-19. So that's more dangerous than the other levels. So we still need to know all staff at the healthcare facilities must wear medical surgical masks. And if we doing some area with level 1 protection, just the general outpatient department, but we should pay attention. If the staff working in the emergency department and outpatient department of infectious disease and so on, And this department maybe have more a high risk of contact with confirmed patient or a suspected patient. So you should change your mask to medical protective mask and N95. And the third one, the staff must wear a protective face cream based on level 2 protection while collecting respiratory specimens from suspected or confirmed patients. So based on the 3 levels, but some special situation, you should change your mask or wear some protective face screen. So next, I will talk a little about guidance of donning and removing PPE to manage COVID-19 patients. So I think every nurse or doctors should be trained for the protocols for donning or removing PPE. So I think everyone should know this. So I don't want to explain it further. Just remember, donning PPE usually is safe because the stuff all is clean. But it's dangerous when we do removing PPE. There's some possibility to get some infection of the virus. So you can see the step very in details, but you should remember before we do each step, wash hand before and after each step. So wash hand before you remove your mask, and after you remove your mask, you should wash hand again and go ahead the next step. So removing PPE is very, very dangerous, so be careful for each step. And the next, I want to talk about if the staff get some exposure to the exposure of the COVID-19, how should we do? So that's we usually care about the question. So you can look at the chart on the left. If the staff get some skin exposure, you should remove the contaminant with clean tissue and apply 0.5% iodophor or 70% alcohol to the skin and wait for 3 minutes for disinfection and thoroughly flushing with running water. If exposure of mucous membranes such as the eyes, flushing with plenty of normal saline or 0.05% iodophor for disinfection. If sharp object injury, so squeeze blood out, flushing the wound with running water, disinfection with 75% alcohol or 0.5% iodophor. If directed exposure of respiratory tract, immediately leave the isolation area, gargle with plenty of normal saline or iodophor, dip a condom swab into 7.5 alcohol and wipe in a circular motion with the nasal cavity gently. After all above the step, evacuate from the isolation area and enter the designated isolation room. Report and isolate and observe person with exposure other than intact skin exposure for 14 days. In case of symptoms, report to the relevant department in a time manner. So for the staff protection, I want to emphasize key points that for me, for my experience, I think the following five tips is very important. The first one, you should make sure you have no correct protection, and remember wash hand immediately when you do some clinical work, and limit your work time, have adequate sleep, and you should eat well and have a nutritious diet, and keep a good mood, have an optimistic attitude. So all the tips will help you have a best immunity can against the virus. So next topic is about management of children with other non-COVID-19 related healthcare needs. I think some doctor will care about this topic because except COVID-19 infection, most children maybe have just a normal disease. So in our hospital, in our city, Wuhan city, so the government will separate the hospital to two types. One is COVID-19 designated hospital. The other is general hospital. So for our hospital, is identified to a general hospital. So if the children have fever, cough, shortness of breath, or sore throat, they will think about this suspected patient will suggest to the designated hospital.
李医生，你那个白板你拨一下，上面有2条线。那你就 stop 再重新笑一下也可以。
哦，可以清楚。
Okay, yeah,
okay. So let's go ahead. So our hospital is a general hospital. We will take care of the children with tumor, chronic disease, including kidney disease or heart disease. And we will still take care of the premature infants. So for general hospital, we usually take care of the patient in outpatient and inpatient department. So outpatient department, we just make sure the doctor can do the hand disinfection before and after consultation. And we use level 2 protection equipment. If the children have serious severe diseases, they need to admit in the ward. So 3 items are needed to perform before the admission, and including COVID-19 nucleic acid testing and antibody testing, and the CT scan in lung. Including the patient and the patient's parents, they should do the 3 items. So we call 3 plus 3. So after the patient settle down in the single room in the ward, and they will receive another, the second time, nucleic acid testing. If negative in all tests, the patient will exclude the possibility of a COVID-19 infection. So Next. Except inpatient, outpatient department, we take care of our patient. We still do some online consultation clinic. That's for so many people in Wuhan. They offer the online clinic. It's free for children and adults with any symptoms all over the country, not just in Wuhan. And we offer 24 hours and 7 days. So if the patient or the parents have any question about the children or adults, they can submit a question. And the doctor will give some suggestion and comment on their worry about the mood, and prescribing and mailing drugs to them, and just take care of some chronic disease. So that's all for our topic today. So this slide, I want to summarize some experience and lessons in Wuhan COVID-19 infection. So I think the first one is very, very important, controlling the source of infection. Early detection, early diagnosis, early isolation, and early treatment. So from the beginning of the pandemic of the COVID-19, so many patients come out, and we for hospital, the doctor and the nursing is very busy and couldn't take care of all of the patient. So the early detection is the first step to make sure which one is a suspected patient or confirmed patient, and do some isolate them to the single room, and then give the early treatment. That's very important. And for normal people, just no symptom people or healthy people, I think the personal protection is very important, especially for our medical staff. And all people suggested to be sure to stay at home. That means save lives. Okay, that's all. Thank you. This is our department picture. Thank you very much. That's all.
So I will share the screen, okay? I will share the screen.
Now I'm sure you all are going to ask a lot of important questions. So let me turn the mic back to organizer, Mr. Gong.
So Dr. Zhu, can you unmute yourself? Dr. Zhu.
Okay, yes.
So can you, there are some questions people posted in advance. Can you state those questions and ask Dr. Zhu?
Right, so actually I categorized the questions. The first, I would like to talk about those PPE. Quite a few questions on reuse PPE due to its shortage. Yeah, I will ask Dr. He to share her experience. How would you reuse N95?
Okay, based on current data, COVID-19 virus can survive on the plastic or paper products for up to 72 hours. So we developed this strategy to maximize the use of a mask. After using a mask for one shift, leave the used mask in a paper bag and let it air dry for 3 to 4 days, and reuse it after the resting period. This way, when you use a well-rested mask, there will be no active virus on the mask. I posted the simple example for my office staff. Take 4 masks and 4 paper bags. mark them as number 1, 2, 3, 4 with your initials. On day 1, you use mask 1, then let it dry out for 3 to 4 days in your paper bag 1. On day 2, you use mask number 2 and let it dry out for 3 to 4 days in your paper bag 2. Same for day 3 and day 4. On day 5, you can use mask number 1 again.
Okay. Dr. Hood, have you used UV light C for disinfection?
Yes, we do. We have a designated room to see the patient with a fever or cough, and we seal the HVAC in and out and outlet. We have a UVC light, and so after every visit, we will use the UV light to clean for 15 minutes. And also our scrub and the bag before we go back to home, our clothing will be all use UV light and sanitize for 15 minutes.
Okay, thank
It all
you.
depends on how big is your room and what's the power. But for my for the small room and my UVC light and 15 minutes will be enough.
Mhm. Thank you. Next question is like, say, compared to adults, children present definitely less severe in the symptoms with a much lower mortality rate. What is the explanation here? Can Dr. Wu or Dr. Lee answer the question?
Please unmute yourself. Oh,
Okay. Okay. I think this question maybe I have some point to explain the severity of the children is less than that of adults. From some points. The first point, I think children usually well taken care of, well cared for at home, and might have the less opportunity to exposure the confirmed patients or exposed to pathogens. This is the first one, and the second one, it is reported that it might be the ACE2, the receptor of the cells for the coronavirus. The ACE2 might be lower than in the children than in adults. The third one to explain this point, I think maybe the children usually get the in upper respiratory infection in the winter, so maybe they got the cross infection antibody against the virus, then get more the antibody than the adults. The last point I think is the children immune system is still developing. For example, the lymphocyte is the priority system in the development. So it might be the point that the children may respond to the pathogens differently to adults. But I have to say the underlying mechanism for the difference between adults and the pediatric patients is still unclear. We need to do the research. Will remain to be underlined. Thank
you. Next question is, what is the main transmission route in children? Is it through family, community, or school?
Based on the data from China, close contact with family member is the highest risk for pediatric patients.
Mhm.
I think this result might be the resulting from the winter break of school in Chinese during this pandemic. It's just in the winter break. So the data from China, the close contact with a family member is the risk. No data from school, no data from the
Community.
community.
Mhm. Okay. Next question is to Dr. Lee. This is about protection. A question about mask. Is universal mask recommended? What percentage of the general population in Wuhan wear masks? Do you feel wearing masks help reduce the transmission?
So we know, so for COVID-19, the transmission is mostly by air. So our government, especially at the beginning of the pandemic, suggests that every person should wear the mask, especially if you have to go out for work, you have to wear a mask. If you go outside, don't wear the mask. The policeman will ask you to wear. And for our medical staff, when we go into the hospital, everywhere we should wear the mask. So for the healthy people, just the normal people, we should wear the mask in Wuhan. Until now, we still have to do that. That's a very simple way to protect ourselves, I think.
The second question is also related to protection. This is talking about in a hospital. If one does not have access to N95, any other mask useful in preventing transmission?
Mm-hmm. So if our medical staff don't have high risk to contact with confirmed person, confirmed patient, so we just use the surgical mask. That's enough. So if you do some high risk work to contact with suspected or confirmed patient, you have to wear a protective mask and N95.
Okay, so if I understand correctly, at the early stage of the outbreak in Wuhan, there was also a severe shortage in the N95 or other protective gear.
Mm-hmm.
How did you deal with the situation at that time? Like say, so even in that like high risk situation,
Right.
yeah, and then at the time you didn't have N95. What, like say you just use surgical mask or
yeah. So at the tough time, we don't have enough N95. So one way is reuse the mask. That's not suggested, but at that time we have to do that. Mm-hmm. And the other way we can just use the surgical mask. But remember, we can wear some full face devices, protect devices, can reduce the possibility of infection.
So next is a few questions on the treatment. So in the United States, for adults, hydrochloroquine with erythromycin were approved for COVID-19 treatment. And then a lot of centers also doing trials on remdesivir. Have you had any experience on those medications?
Actually, we have no experience of the chloroquine, but also we have no experience on the Remdesivir. Since the Remdesivir still in the clinical trial, I know some adult patients is under this clinical trial. It should be phase 3 in China. But for the children, for the pediatric patient, we have no clinical trial on them. And actually, we have no experience on the chloroquine. But I did have experience with the combined drug with the 3 medicine, like the Abidor and azithromycin. Yeah, azithromycin and Alzheimer. These 3 combine these 3 medicine for the children.
Yeah. Okay, right. So on your slide, you list several antiviral medication. The question is, when do you initiate the antiviral medication? And among those antiviral medication you have experienced, how did you have any preference? Like say, oh, this is the first line, that's the second line treatment. How do you choose which one to use?
As I said, different type of parents, different type of patients, different treatment. So I think for all of 5 categories of confirmed patients, all need to get some treatment. I mean, general treatment is still treatment. So for the antivirus medicine, for the antivirus drug is also used for all of the 5 category of patient, but it depends on the condition of the patient. This is just one of the combined strategies. So Alzheimer and Abidor, and I said the azithromycin also have been used for the first type of the patient, even first type of patient.
You mean the mild patient with mild symptoms?
Right.
Yes.
Right.
Okay. Let's see. And then when you use the antiviral the anti-influenza medication, is because you suspect the patient and has a co-infection with influenza, or this is say primarily treating COVID-19?
Actually, the difference is hard to tell. I mean, the influenza, COVID-19, or RSV infection, it's hard to tell. Depends on the clinical features. Just the manifestation is hard to tell. We have to order the examination. That's what I have said in the slides. So for the clinical manifestation, I just want to say the COVID-19 patients may present a low grade of fever or no fever, but the influenza, the patient with influenza might present the fever with a high degree. RSV always happen the age below 3 years old. Half of the infected cases happen in the below 1 year old. So maybe help you to tell, but you still have to order the examination.
Okay. So I'm talking about in the United States, in the outpatient setting. Nowadays, we actually do a lot of telemedicine, so consult patient over the phone. And then, so like say patient presented with say cough, fever, or fatigue, and we have the suspicion, And then if the patient had, say, mild symptoms, I would say in a lot of places, they probably don't even meet the criteria to be to have this viral test. Okay, so basically advise patient to be monitored at home. In this situation, what would you advise the parents?
From my opinion, I think the oxygen saturation is a very important indicator. Since the patients is divided into 5 categories population, for the first 3 population, we can encourage them at home. But how to prevent or how to identify the patient, the progression in the patient, which patient will progress into the upper level? I think the important point is the oxygen saturation. That means you have to identify the hypoxia to monitor the hypoxia in the patient. So if you can monitor the oxygen saturation, it's good. Otherwise, you have to monitor the signs like the short of breathness. But here I want to talk more. Just the experience from the ICU doctors. I don't know if you heard the term silence hypoxia. Silence hypoxia. That means the patients don't have the hypoxia signs. They don't have discomfortable since they just rest in the bed. But actually, his oxygen saturation is really very, very low. But if you don't detect it, you don't know. And when the patient raises up to work, the danger will happen. So that means silence. This patient looks like calm, looks like okay, fine. But the oxygen saturation is very low. You don't know. You have what I want to say, you have to monitor, and you have to provide the oxygen therapy in advance to prevent the progression into the disease.
Okay, so I assume in China, even those patients with mild symptoms, they will be in the hospital instead of staying home.
Which population?
Just let's say the stage 1, those will be in the hospital.
In China, once the person is confirmed, the laboratory is positive, they will be transferred. They will be isolated immediately and was transferred to the casual hospital. I mean the designated hospital. Mm-hmm. And the designated hospital is were divided into different levels.
Mm-hmm. I see.
Yeah.
So it seems like here in the States, we may want to suggest parents to get a post-op machine to check their kids. Yeah. And then so you list the discharge some criteria. I'm curious, like say, if a child have say 2 negative viral tests, is he going to go home, have a normal life, or he's going to be quarantined at home for a period of time?
You mean after the twice negative result?
Right.
Yeah. Once the patient was admitted into the hospital and then get the treatment, and then check the laboratory results return to normal, like the twice time of the virus testing is negative. He was discharged, but he cannot get back to home. He have to be transferred to another isolated area. Maybe it's a hotel. Maybe that's the some room in the college. And then isolated, and then have to be isolated for another 14 days. Then he's released.
They're released. You can go home and then hug parents.
Yeah.
Okay. How often do you see asymptomatic patient?
Actually, I have till now I have the data. I have the native data. How many? How the instance? But I did see the asymptomatic patients. One of these kind of patients is the is a boy. I just give an example. This boy don't present any symptoms, but he want to get a pre-admission examination. He want to be admitted into hospital for chemotherapy. So he got the screen examination. Then the virus, the swab for RNA test is positive, and then we serve the family history. His mother got the infection. So I want to say the symptomatic patients always infected from the exposure from traveling. That is the two main ways, and the contiguous level of confirmed cases is much stronger and much higher than asymptomatic carrier. Why I to say this? Because I read the data from some information. I read the information from the publication from adults. So the contiguous power is much stronger and much higher in the confirmed cases than in symptomatic carrier.
Oh, I see.
Dr. Zhu, can I ask one of the audience to ask a question?
Sure.
Serena 2, are you there? Serena 2 from California. Guangqing Han? No. What about Therensa Yin from San Francisco? Are you there? Northeastern Medical Center.
Have you?
Okay, Dr. Zhu, go ahead with your question.
Yeah, if you can you share this, like say, share the slide? Put the slide, I think it's Dr. Wu talk, I think the first slide, very first slide, talking about patient number and confirmed case. Yes, this is the one, a confirmed case versus the suspected cases. Yeah, just, it is interesting to see, like say, 1/3 patient is confirmed and 2/3 is suspected. So 2/3 patient actually didn't have positive nucleic acid test. So I see, okay, it seems like the false negative rate for this test is high. Is that right?
Can you ask a question in Chinese? If 需要用汉语说吗？问题。
Actually, yeah, actually for the criteria for suspected cases and the confirmed cases, the difference just the laboratory positive.
Right.
I mean, yeah, the virus positive. But the test case has false negative is just only one problem, only one factor. Another since another issue we need to consider.
143 pediatric patients.
Sorry?
731 were laboratory confirmed, 1,400 were suspected.
Do you, can you say it again?
Continue your question.
Okay.
Pardon? Yeah.
Okay. I want to say the false negative, just only one reason. Another reason maybe another reason you have to consider the suspected cases might be not the, I mean the real in fact.
Yeah.
Yeah, because the CT, the chest CT imaging presented the seminal virus pneumonia, but the virus test is negative. It might be resulting from other virus, other pathogens, like the fungus.
Right. So when you say suspected case here, this, do you consider this a COVID-19 infection?
We have the criteria. We have a criteria. I already listed in my slide. So
right.
you have to meet the criteria, but sometimes the patient don't meet the criteria.
Right.
So suspected case, but it might be infected from another pathogen. We have to think about it. We have to consider this point.
Right. So how do you manage those cases?
Okay. Usually, this is depend on the time. At the initial time, we will have to isolate the suspected cases in a single room, one person in one room, and then monitor. And then at that time, we call this is the clinical confirmed cases once the chest CT presented the typical virus pneumonia. Do you understand? And then with the time passed later, we don't consider this kind of situation. We just depends on the laboratory positive. And
right.
for the laboratory positive population, for this population with active, negative. For this population with laboratory negative, we just keep monitor. Once they recover to normal, once the symptoms disappear, we just keep monitor for 14 days. If the laboratory result is still negative, then they will be released.
Right. So what are the follow-up on those suspected case? What percentage eventually had positive nucleic acid test? Do you have any idea on that?
No, I have no data. I have no research on this. I didn't check this data from publication.
Right. And then do you give antiviral medication on this type of patient, suspected cases?
Yes.
You do?
Yes.
So basically you manage the same as confirmed case, is that right?
You mean
the suspected cases, and you like say you gave antiviral medication. It sounds like you manage similar to a confirmed case.
Yeah, depends on the situation, the patient's situation.
Right? Like say patient's symptoms.
Right.
Okay. Yeah. All right. Tom, do you have any doctor asking a question?
Yes, hold on 1 second. Chad, do you have a question, Chad?
Yes, I do. Can you hear me?
Can you state your name, your city, and your organization, then ask your question. Go ahead, Chad.
Thank you very much. So the use of serology for antibody testing for pediatrics who have mild upper respiratory symptoms without any positive RNA PCR testing, what is the use of the serology test for those who may have had mild symptoms but never tested positive for COVID-19? Thank you.
Chad, can you state your city and organization again?
Yeah, sorry. I'm a general pediatrician in Boca Raton, Florida, in the United States.
Dr. Zhu, did you get the question?
Yeah.
Can you translate the question into Chinese?
看李医生和吴医生听懂了吗？
你的手可以拿起来，就用汉语说一遍，他说的蛮快。朱医生把问题
他就是说，检查那个就是血清里头那些抗体的检查，就是对那些他就是抗体检查的用意是什么？就是如果说病人只是很轻的症状，然后他的那个核酸的检查又是阴性的话，这个抗体的检查有什么意义？
我来说，你来翻译行吗 ？OK， 可以吗？
他们有听到吗？
不是，如果我来说，你来翻译行吗？
可以。
哦，可以。
是这样的，就是我们现在是用核酸的假阳性率很高，所以一定要做抗体检测。那么做抗体检测有2个好处，第一个可以帮助诊断，第二个同时看一下孩子是不是处于哪个期，如果是感染的孩子处哪个期。第3个方面还可以做一些流行病学的调查，就是因为我们很多孩子没有症状，他可能感染过，就到底发病率的情况可以有所了解。
金主任，你就说那个感染的哪个期，这是能说？
他比如说，他有时候是，比如说我们有抗体产生，肯定不会是潜伏期了，他肯定是发病了，发病了，也许他处于发病的急期，也可能处于恢复期。你比如他就是个 IgG 阳性 ，IgM 阴性了，他可能已经恢复了好了。
Okay, I see. Okay. Yeah. So I think the question is asking the purpose for serology test. In my case, so even the patient has negative nucleic acid test. One reason is because the false negative rate of the nucleic acid test is high. That's one of the reasons they do the serology test. The second reason is obviously this for the epidemiological purpose. The third reason is it can identify patient, like say, which stage they depends on, say, IgG titer, IgM titer, say which stage the patient's during the acute phase or during the convalescence phase. So it is helpful using the serology test. I don't know. Did I answer your question?
Chad, did that answer your question?
Okay. Yeah.
Chad,
Yes.
did that answer your question?
The question is for our children in the United States who it's very difficult to test pediatric patients now in the United States, especially those with mild symptoms. So can we use the rapid serology test to determine which children may have been infected to know that they are now immune and can maybe resume activities in the community in the weeks and months moving forward?
Yeah, 他就说，因为现在这个在美国做那个核酸的检查很困难，那他就说用这个就是抗体的检查，是不是能够知道那个小孩子有恢复了，已经产生免疫力了，然后可以回到他正常的呀，上学呀，回家呀，就是可以回到正常的生活，就是这个就是这个免疫。
他如果说这个孩子如果说 IgM 和 IgG 全部阳性，这时候还不知道他有没有可能有传染性。如果是仅仅是 IgM 阳性，那么这个孩子他可能还是早期，他可能还有传染性。如果说他是 IgG 阳性 ，IgM 已经阴性了，那就说明这孩子以前感染过，他现在应该来说是没有问题了，他可以上学，可以怎么样都可以。
I see.
就是分3种情况，一个单纯的 IgM 阳性，一个单纯的 IgG 阳性，还有一个是2个的阳性，这个都要考虑到。
对对，所以就是你意思说，如果病人他 IgM 阴性了，他只是 IgG 阳性，那是他已经有免疫力了，那是可以就是开始正常上学啊，这样子。
对，那应该是可以了。
Okay. Yeah. So, Dr. Jing said like it depends the IgG IgM level. If the patient has say IgG positive, I'm sorry, IgM positive, IgG negative, that's like say during the infectious period. If IgM and IgG both positive, we're not sure. It's probably still recovering, but we're not sure if the kid's still infectious. But if patient has only positive IgG, negative IgM, that might be indicating that it recovered and he has developed immunity and can go back to a normal life. Okay, yeah.
Okay, David Brett, are you there?
Yes, I'm here. David Bratt, I'm a general pediatrician in private solo practice in Port of Spain, Trinidad and Tobago. And I have a slightly different question. I'd like to know, why do you think there hasn't been a second wave of COVID-19 in China?
他是问就是为什么会没有到现在还没有第二个高潮，就是这个COVID-19 这个感染，为什么在中国没有发生第二个高潮？
中国之所以没有发生第2次高潮，我想这是非常复杂的问题。第一个是主要，我觉得还是我们中国的政府管得非常的好，应该这么说。然后我们的老百姓非常配合政府在这工作，因为我们基本上现在到目前为止，比如说武汉市还没有解封，我们的小区里面还是在进行管理，也就是说，然后第3个就是说我们的所有的只要检测有病人的，一定是去隔离了的。这所有上班的人员都要做相关的核酸检测、抗体检测，就排除他不是病人。那即使他做了检测，他上班以后还要戴口罩来防护。并且还要去注意手的卫生。所以我觉得还是第一个，政府的管理还是比较好；第2个，老百姓比较支持政府这些管理方法。做得比较自觉。第3个，我觉得就是那个检测已经比较到位了。你看现在所有从国外到中国来的人群，全部要进行检测。也就是说是为了防止它出现发作。然后即使我们发现一个，因为我们在检测筛查的时候也会发现那就无症状的感染者。无症状感染者，我们其实也把它当成病人看待，也去把它进行隔离。所以从源头上来控制了这种疾病，所以说我们没有发生第2次，所以我们现在也怕发生第2次，因为其实国家承受不了这种打击。我们实际上是严防严控，就是把那个传染源先堵住，第2个把传播途径尽可能把它阻断。
好。
那么第3个最后一个，可能中国还有一个好处的，就是说我们可能这段时间大部分人都在休息，不那么劳累，然后我们还有一些人是用了一些中医药进行防护，然后把营养方面，因为我们的基本的营养物质的是不缺的，人民的基本的生活保障是有的，所以他们营养状态也还好，所以我们的易感人群的体质也是比较好的，所以我想在这几个方面可以防止了它的第2次的发作。
朱医生，你先等一下，我跟大家说2句。So, in the audience, if you want to ask questions, raise your hand. So, and also mark your city and organization. I can call on you. Okay, Dr. Zhu, go ahead.
Okay. So Dr. Jing said the answer is quite complex. So meaning that we haven't seen the second wave of COVID-19 infection in China. The explanation is complex. First, he said it's from the government. It's a really tight control, and then taking slow, very cautious step. And then the people all over the country is very cooperative. And by this time, like say the lockdown in Wuhan is not lifted yet. I think it will probably in a couple of days, but it will be a really slow stepwise lift. And then the testing, it's really testing widely available for, like say, for foreigner or like say tourists coming to China, they should all be tested. Basically, so anyone present any symptoms will be tested, and then the confirmed case or suspected case will be isolated. And then for the patient, so stepwise patients are allowed to return to work, but they have to go through quite a few tests to get clearance to be able to go back to work. Like they need to have, say, a negative nucleic acid test, they need to have a CT, and even serology tests. I mean, I know in the hospital or the staff, before they'll go back to work, they need to have this test. And the similar rule will apply to those workers going back to factory. Even they have all the clearance, they're going back to work, they still wear masks. The other thing Dr. Xing mentioned is, because all this time lockdown, the folks are all resting home, so they had a good rest, and then they have a good supply of, say, food, and so they prepare food. They probably have more nutritious food during this period. And then the herbal medicine, traditional Chinese medicine, is say a very common practice in China. So a lot of patients, even normal healthy people, taking herbal medicine. So all these, like say, resting nutrition, herbal medicine, they all help boost up their immunity, so they are less susceptible for the infection. Yeah.
Okay, Dr. Lin An Wu, are you there?
Yes.
State your city and your organization, then ask your question.
Sure. So my name is Ling An Wu. I'm one of the general pediatricians in Salem, Oregon, United States. I have two questions. The first is that how do you define fever regarding to COVID-19 patients? Here in the United States, we were trained to use 100.4 Fahrenheit, which is 38 Celsius. But I think in China, maybe they're using much lower threshold, like 37.5 Celsius, which is actually 99.5 Fahrenheit. My second question is, have you seen any reinfection patients with COVID-19? Thank you.
医生翻成汉语。
他就是问，他是两个问题。第一个就是说，怎么定义发热，就怎么定义发烧。在美国呢是定义成104华氏，摄氏是38度。那他知道中国好像发热这个定义的更低一些。第二个问题是问有没有再感染，就是这个新冠病毒再感染的例子，你们有没有见到？
好，谢谢他的问题。第一个，我们确实是把温度降到不是按照那个的方法，因为我们中国的儿童我们是37度5，超过37度5就是发烧了，而我们成年人为了更少的。就是更少的能够忽略，就会有些病人就怕忽略掉了，所以说我们是定了37度3，就是它这个温度，因为我们在中国人看来就是37度5到37度38度，其实就是已经是低温了，就是低烧了。 已经开始发烧了。那么就是说，所以说我们的只要的，所以说我们现在成人是37.3度，这个儿童是37.5度，这就是我们温度的定义，可能跟你们上面外面不是一样。其实我们在儿童血液方面，我们的发烧定义是38度，是我们住院的病人定义38度。并且我们是要持续1个小时以上，这是我们在住院的儿童，就是白血病的孩子，我们是这么做的。但是因为这个疫情太重，为了尽可能减少落诊的病人，所以我们尽量是比较低一些。这是第一个。第二个问题还是什么问题？
他是说有看到那个
就是扶阳的问题。
对，
等一下，让他先把第一个问题。
现在确实有这种情况，就是他已经好了，后来回家，后来发现又复阳了。复阳了，后来现在很多专家现在认为是这种情况，就是说第一个他可能是残留的核酸在体内，第二个是可能这个病还没有完全好，因为那时候病人太多了，很多病人就是比较早期复阳的比较多一点。因为他当时只要是体温3天以上正常了，那个肺部 CT 没有没有加重，症状没有加重，就觉得是控制了，就让他现在出院了。其实很多病人是没有完全治好，出去以后又发作了。但从我们儿科里面现在发现另外一个现象，确实我们一直也没搞清楚，就是儿童患病的孩子过了2个月以后，他的咽拭子核酸是阴性，但是大便里面检查还是阳性，就是刚试还是阳性，但到底它还有没有传染性，也就是从消化道还有没有传染性，这还需要进一步的研究。因为我们就说要把那个大便要做培养，看它的有没有完整的活的病毒，因为也可能是残留的一些核酸，残留核酸就没意义。
但是这个不知道这个就大便里头的那个病毒是有没有活性，这个还是不知道。
这孩子需要再进一步做研究，因为我们是现在医院，他不能做这方面工作，不能做这个病毒培养。
I see. OK. 但是那个小孩他来随诊那2个月，那个时候他都没有，应该是没有症状的，只是
他没有任何症状，因为现在我们国内的医生也在观察，到底他带毒有多长时间。因为我们从医院的角度吧，只能做那个核酸检测。做核酸检测确实现在过了2个月以上的都是阳性。他们有问我怎么办，我说这些孩子没症状，就还是在家里待着。但是就是还是要注意，第一把手洗好，第二个就是在家里接触人的时候，还是最好是戴口罩，或者出去的时候。但是他因为咽拭子是阴性，他呼吸道传染可能性很小了。这个时候我们主要就怕他有消化道传染，所以一定小孩上了大便以后，或者吃东西之前，一定要求给小孩洗手，并且洗手至少30秒以上。
那这种小孩他那个，
吴医生，你抓紧回答一下。
有没有这个小孩他的 IgG、IgM 呢？他那些检查是怎么样呢？这样的小孩就是大便里头阳性，这样的小孩多吗？
不是很多。有些孩子我们在儿科也发现这种情况，但IgG、IgM 这个病人不是我的病人，是我下面医生的病人，他们那还不能做 IgG、IgM。所以说我就没有办法来回答这个问题。我已经建议他们一定要做 IgG、IgM。
对，再就是我再问一下，就刚才说的那些温度，我们是量的口温，是量的肛温，是量的哪地方的温度？
我们是量的腋温。
腋温。Okay. Yeah. So to answer the question, for the definition of fever, the criteria they use in Wuhan is 37.5 Celsius and exhaled temperature. This is for children. For adults, they use 37.3. I want to point out this is only for the screening COVID-19 patient. Dr. Xing said for their say hematological like say in their regular practice, they used to use 38 Celsius to define fever, but just at this pandemic period, they don't want to miss any patient. That's why they lower the threshold. So it's a 37.5 for children, 37.3 for adults. Regarding this reinfection, it's not clear, but they do see cases like, say, a patient turned, and when they went home, the test turned positive, or they had like say, recurrence of symptoms. The explanation is probably they have not totally recovered. This case is presented earlier during the outbreak. At that time, like say, the hospital sort of overwhelmed. They discharged patient probably prematurely. The criteria at the time is patient had no fever for 3 days. There's some improvement on chest imaging. The patient was sent home. And then that's probably explain like say, the recurrence of symptoms. They just say the patient was not totally cleared of the infection. A second phenomenon they observe is nowadays, say for kids recovered from COVID-19, when they came back for 2 months follow-up, they were doing well. They had negative oropharyngeal swab, but they have positive nucleic acid in the stool test. And then so the Dr. Ching saying they are not clear. The virus in the feces is like a live infectious virus, or just a fragments of the nucleic acid. So that still needs still more work to figure out.
Did you finish answering that question?
Right.
Okay, Keisha from Mexico City, are you there? Keisha Contreras?
Yes, I'm here.
My name. Can you turn on your video and state your city and organization, then ask your question?
Yes. My name is Katia Contreras. I'm from Mexico City. I'm a general pediatrician and also a lactation consultant. Mm-hmm. And I would like to ask you, thank you very much for your generous talks and speech. We are very grateful. And I would like to ask, we heard at the beginning of your class that the youngest patient you had is 1.5 months. But I wonder if you have done like some investigation on the delayed cord clamping in a baby born to a COVID-19 positive mom. Also, what's the breastfeeding issue with a positive mom, and why do you think many newborns are having negative tests? I've heard that you haven't had like any intrauterine or vertical transmission of the disease, but do you think there will be some immunological or something with the test that maybe it's very contagious disease? And I'm wondering, I have been like reading a lot of babies that are with negative tests with positive moms. And should the baby be isolated from the mom if the mom is positive?
What is the, I'm sorry, I missed the first part. So you say on the slide, the youngest patient was 1.5 months. Are you able to hear me?
In your experience, yeah, I hear you.
Mm-hmm.
Yeah.
Okay.
That your youngest patient.
Right, it break. Okay, let me just ask those questions I got. Okay. Yeah. So the question is about newborn and with
汉语讲
oh yeah, I'm sorry. 就是他是儿科医生，然后他也是做很多那个就是母乳就是他帮助妈妈做母乳喂养的，那他的问题就是说，在吴医生的那个 slide 里头，就是讲到最小的小孩，最小的那个病人是1个半月，那他就是问这个，就是如果说母亲有这个病毒感染，它对新生儿的危险到底有多大？虽然就说我们在吴医生的那个 slide， 就是他的 presentation 里头就提到说没有宫内的感染，他就说那个小孩新生儿出来做检查也是做的核酸的检查，那因为核酸的阳性率就是就是假阴性率也很高嘛，那就是说是不是没有测到？就是你们在这方面有没有研究？再一个就是这个如果这个新生儿是不是需要给妈妈隔离？如果妈妈是阳性，第3个问题就是讲哺乳，那个就是说如果妈妈是阳性，那个母乳喂养会不会有危险？然后如果说母乳把它泵出来喂孩子，可不可行？
麻烦吴医生回答一下。
Yeah, I want to answer the last question firstly. In my opinion, the baby should be isolated.
It's okay. We can hear you. Yeah. We can see you. We can hear you. It's fine.
Okay. In my opinion, the baby should be isolated from the mother with positive. So this is the last question. I think it should be. The second question is the
breastfeeding. Yeah, breastfeeding.
Yeah.
母乳这一块。
Yeah. Actually, we did test the serum for the RNA, for the virus RNA virus RNA by RT-PCR. The result is negative, which means the virus loading in the serum should be very low. So I just assume supposedly the virus in the breast milk should be very, very low. But I still encourage the mother don't use the breast milk for this baby, even though we cannot detect the virus RNA in the serum in the breast milk, but till now we didn't check the virus virus loading. So in my opinion, I still encourage the mother don't use the breast milk for the baby. This is the second question. The first question is the
他是讲那个就新生儿，你们就是如果说母亲是有阳性，你们新生儿都是有检查。
I got the question. Since I showed the data is from CDC, is from the publication. So the baby with 1.5 months is not my patient. But I think we need to monitor the babies, monitor the signs, symptoms, and keep the test the virus. Also, we can test the antibody after one week. Maybe IgG positive can indicate the infection. But if the baby keep active for virus testing, active for antibodies, I think we can make sure this baby is not the intrauterine infection.
Thank you.
Dr. Zhu, I think there are some other questions people sent it in advance. Some other from a couple of professors. Did you ask those questions?
Yeah, like mostly we answer all the question, and then Dr. Lee and Dr. Wu, they also include those, like say, it also covered in their speech.
Okay. Hiwis from Jakarta, are you there? Hello, Hiwis. Hello.
Hi, Tom.
Yeah, just state your organization and then ask your question.
Yeah, I'm Linus. I'm a general pediatrician from Jakarta, Indonesia.
Mm-hmm.
My question is, during this season of COVID-19, it's been very popular for the radiologist to read the CT scan of the chest as a ground glass opacity, which actually many will refer it to COVID-19.
Mm-hmm.
My question is whether you can differentiate this radiologic finding in the CT scan of ground glass opacity in COVID-19 compared to other viral infections. As you know that RSV can cause pneumonia, metapneumovirus, you can also have influenza, mostly giving more or less the same appearance or reading in the CT scan. The reason why I ask this question is because we do not have this kind of luxury to have an access to the serologic test or the swab test to prove it whether this is COVID-19 or not. And then it affects the patient's hospitalizations, because many hospitals are not ready to accept a suspected case of COVID-19. Thank you.
Okay. 这个是印尼的医生，他就是问，就说那个我们讲在 CT 胸部 CT 检查上，就是经常会看到这个毛玻璃的阴影，两侧双侧毛玻璃的阴影。那其他的病毒性的肺炎也会有类似的表现。他就是问，那这个就说那个这个新冠病毒的肺炎是不是有一些更就是说就是单从影像上是不是就能看出是新冠病毒肺炎？能够区分新冠病毒的肺炎 versus 其他的病毒的肺炎，因为在他们那里就是这个病毒就新冠病毒的检查还有血清的检查都不是很能够做，所以都就是不容易做到那些病毒啊或血清的检查，所以他们要诊断这个新冠病毒就不是很容易。他就是希望希望听听你的意见，从影像学上。是不是能够区分这个新冠病毒和其他的病毒？我不知道我说清楚没有？
很清楚。我来回答算了，好吧？是这样的，毛玻璃是个常见现象，很多感染都会出现。在成年人里面，它可能肿瘤、肺癌也可能会出现。那么在儿科里面的，就是说，比如说很多病毒。比如说支原体感染、衣原体感染，还有其他的一些病毒感染，都可能会出现这种情况。所以说，我们不会把这个 CT 只是提示可能有这个肺炎，而不能说确定诊断。我们湖北省曾经有一段时间这么做过，当时主要是想尽可能快把病人收治进方舱，短期做过，后来我们就又取消了。所以我们诊断的金标准还是的核酸和后面的抗体。还是正常快，那么就是说，但是我们如果说他们那个地方，如果说不能做这个方面检测，我觉得有个比较好的，其实我们医院很早就开始做了，比如说我们在门诊就做5种常见呼吸道病毒感染的，比如说支原体感染、衣原体感染，还有核化病毒、腺病毒，还有流感病毒，这些病毒都把它排除掉了。如果排除的都没有， 而儿童基本上是没有肺癌的。菌感染和其他感染可能性也很小，没有基础病。如果说把那几个常见的病原体感染排除掉了，那么我们当然就是说，当然我们可以说考虑在这个流行季节，应该来说可以进行临床诊断，就是我们把临床诊断来新冠病毒感染，我们觉得是这样的情况。如果说到我们现在我们现在一定是要到我们已经国内一定是要做病毒和抗体了，他们不能做的时候，就采取我个人建议是用排他法，就把其他的病毒支原体、原体等都排除了，然后再来做。这也就是我们很早的时候，最初的时候，我们为什么对这种病人，我们都用抗流感的治疗和抗支原体的治疗，实际上我们用的阿奇霉素，就是因为当时很多混在一起在搞不清楚。我觉得他们也可以借鉴我们的经验。我们当时其实把这2个药物用了以后，我们就发现重病人还是会减少。我们是用的就是奥司他韦，然后再就是阿奇霉素。后来我们又发现另外一个就是用了那个阿比多尔。阿比多尔也是个抗流感的，但是有可能有比较微弱的抗新冠病毒感染的作用。所以我们当时觉得用了以后，它这3个药物一个不贵，第二个就是说副作用比较小，第3个就是说还是我们就发现可以减少重症病人的发生的机会。
Okay. Yeah.
Well, everyone, just housekeeping, because Dr. Jin, he will just speak Chinese, and Dr. Zhu from California will translate into English. But Dr. Wu and Dr. Li can speak English. Okay, just keep that in mind.
Okay. So Dr. Jin said the ground grass opacity is a common finding. Just as the doctor in Malaysia said, in other viral medication or atypical pneumonia, adults even seen in the lung cancer. So you cannot say based on the finding to make the diagnosis of a COVID-19 infection. But like say in the situation you have limited access to nucleic acid or serology tests, he suggests you can do the rule out way. So he said at the early stage, what they did is they do the respiratory panel to rule out, say, atypical pneumonia, influenza. That's why they use a lot of anti-influenza medication like Apidol and oseltamivir. And then they use azithromycin for atypical pneumonia. And then by using a combination of these 3 medications, they do see the efficacy to reduce the symptoms and then to reduce the progression to severe critical stage.
So because of time issue, we're going to ask the last 2 questions, okay? Dr. Hello, can you state your name?
Hi, my name is Audrey Lung. I am a general pediatrician in San Francisco, California in the United States. And my question is, I was curious that during the outbreak, did you continue to do routine well child checkups? And if so, how did you screen the parents that accompanied them to make sure the physicians had adequate level of PPE, such as a surgical mask versus wearing an N95? Thank you.
他就是问在预期你们是不是还继续做就是常规小孩的体检？如果你们做的话，你们是怎么样就是筛查父母吧，就是不会让 有那个带病毒的父母来看，然后会影响到医护人员的健康。
是这样的，我们现在常规体检不会做，但是看病的肯定要做体检。常规体检就是有段时间，包括打预防针，有段时间也停了，现在开始慢慢恢复了。因为我们所有住院的病人，如果这孩子需要住院，那么还是要排除这个病毒感染。然后他的陪护，因为我们国内很多地方还有陪护，他的陪护，不管他的父亲、母亲还是老人，不管是哪个，他一定要做出相同的排除。就包括做 CT、做核酸，或者我们在做抗体，就排除。因为他是安全的情况下，才能够到医院去住院，因为怕影响其他的孩子们。
对对。那现在就是现在开始做一些，比方门诊这样子的。那看门诊那医生是怎么样的防护呢？那对那个陪小孩来看他那些父母需要做什么检查吗？
陪伴的父母和小孩都要做排除新型冠状病毒感染的，他要做核酸，要做抗体，要做肺部 CT。
这是指的住院的病人对吧？如果说
门诊不需要，门诊我们的医护人员防护还是比较好的，我们是要求至少2级防护，就是你可能你要戴口罩，戴帽子，然后最好呢需要，特别是在急诊的时候就需要戴防护面具，或者说戴眼镜，然后要穿隔离衣。
OK， 急诊的时候需要这样。
对，我们普通门诊也可以这样，因为我们现在物质还可以，现在也这样。所以说我们只是说有的医生不大喜欢戴那个防护眼镜，他可能不一定戴。
OK。
当然也可能我们现在有的人是戴了防护面屏，防护面屏就舒服一点，反正就是尽可能保护好我们医护人员。
Okay. Dr. Jin said they stopped a wild child visit during the outbreak. They even stopped the routine vaccination. They gradually resume the routine care right now. So as we said during the presentation, for the inpatient, they do screen the caregiver. So every caregiver needs to get nucleic acid test, serology test, and CT before they can come to accompany the child in the hospital. Nowadays, for the outpatient visit, there's no screening for the parents, but the provider will wear the level 2 protection. They wear mask, the head, gloves, and Dr. Ching said for emergency room staff, they wear the N95 goggle or face shield. Any question? Oh, you are not? I don't think he's muted.
Okay, I'm going to call out the last question, okay, because of time issue. Malinke Tai, are you there?
Yes, I'm here.
Can you open your video if possible, where you are, state your city and the organization, then ask your question.
Yes, I'm from St. Paul, Minnesota in the United States, and I work at Children's Hospital as in the ER as well as in a primary pediatric clinic. And I apologize, I've been gone for a little bit from this call, so I hope this wasn't already asked, but I was curious about the NAT test and what is the false negative and false positive rate that we know of for the nucleic acid test. And the other question I have is about steroid use. We've been really discouraged from using steroids because reports that it can make acute respiratory distress syndrome worse. Thank you.
他是问那个 NAT test， 就是 NAT 那个检查，它的那个假阳性和假阴性的假阳性假阴性率。再一个就是那个激素的治疗，他说在这里都是一般是不主张激素的治疗，因为它可能会加重这个 ARDS，还是想听听你们的经验。
你刚说第一个检查怎么检查 ？NAT 还是什么？
那个就是那个核酸的检查。
核酸检查什么假阴性噻？
对，它是假阴性和假阳性率是怎么样？
假阴性率主要，我个人认为主要还是那个问题，还是取材的问题，因为不同的部位取材是不一样的。比如说你40，它可能取材只有40%左右的阳性率。如果说这个人喝了水以后再去做检查，可能阳性率更低。如果说是痰里面，或者是肺泡灌洗液里面，它就好一些。但是即使是肺泡灌洗液，它只有80%左右的阳性率，就是它肯定有很多人是80%左右，也就是它肯定还是有些采不到这个病毒的。采不到病毒，你怎么说它也是阴性。所以说我们觉得现在试剂来看，应该来说是比较好了，因为这是个常规检测了。现在，常规检查这种，所以说我们不觉得会有假阳性率。因为我们做检查的时候，一定是在非常好的防护的条件下，不会污染。如果污染之后，它肯定有假阳性率。所以我们现在没有发现假阳性率，只要是有阳性的，都会考虑它这个感染的。这是第一个问题。第二个问题，对激素使用一直是有争论的问题。那么就说是因为这种感染以后，它可能会引起我们说叫炎症风暴反应或者急性炎症反应。所以我们现在是主张在炎症反应非常严重的时候，短期使用激素。比如说他可能会有持续性的高烧，可能超过了3天以上，或者说这个孩子呼吸突然一下子加快，或者说肺部的感染突然那个 CT 来看，突然一下子变成像北非一样的了，这时候不用激素肯定救不活。因为这时候我们就一定是要用激素，短期使用激素，小剂量。我们一般来用每公斤体重甲强龙，用1到2个毫克，就是每公斤体重，一般来说用3-5天就停下来。我们觉得这种小剂量激素不会使病毒排泄延迟会影响那么大，但是它可以挽救生命。
OK， 就是刚才他问了那个假阳性假阴性率，有没有确切的数据？比方说咽拭子假阴性率有多高？
这不叫假，我不是说我们就是在假阴性率，就是我们这阳性的，我们就说这阳性大概40%，那你就说额外的60%可能是个假阴性了。
40%。
40%是阳性率，是我采样的以后做出来阳性率是40%。
40%，没事。
那其他的你有肺部的表现，又有核酸的检测，又有抗体检测能够确诊的话，那么就说明另外的还是没有取到，它就是假阴性的。
对。So the first question is about false positive or false negative rate for this nucleic acid test. Dr. Ching said regarding false negative, it really depends on whether you collect how you collect the specimen. Say the nasopharyngeal swab or like say oropharyngeal swab. He said if you say for oropharyngeal swab, if you drink water, it will largely reduce the sensitivity. Also they did from the sputum or the bronchial wash. In bronchial wash, they can detect they have a say 80% of yielding. So it depends on the swab. he said it's 40%. He said, I would say literally it's like a 60% of false negative rate. But they wouldn't say that way. They would say 40% of positive. Yeah, I don't know how to express it better. But anyway, it's false. If to say, okay, if patient has a false, if patient has a negative nucleic acid test, it's still a high chance patient can have this infection. And then he said there's no false positive. There's no false positive because they did this test in a really, like say, clear environment because all the staff were the protection. So there's really low chance of contamination. Regarding steroid use, it is controversial, as we all know. But they say, he said it could be a life-saving measure, especially during inflammatory storm or cytokine storm. The rule they use is say a short course. The symptom for cytokine storm is like, say, it's like a rapid progression of the symptoms. Patient can have high fever more than 3 days, rapid heart rate, and then a really deterioration finding on the CT, like a whiteout of the lungs, of both lungs. Yeah, I think, and he also gave me the dosage and the medication. I need to double check, and I'll put it on the slide. Then they say use that for 3 to 5 days.
Malinka, did that answer your question?
Yes, thank you very much.
Right. So yeah, I need to clarify with Dr. Xing about the dosage, medication, and the course. But he said it's a 3 to 5 days, a short course. Yeah.
殷主任，李强还想给大家说2句吧，最后。
你好，怎么？
你还想
信号不好？
说2句吗？你最后还想跟大家说2句吗？我们现在已经差不多了。啊？你还想不想跟所有的人说2句？信
号不好。
他说信号不好，这样好一些吗？
我没有什么要说的，就首先感谢大家参与。 第二个，希望大家都保护好自己，戴好口罩，洗好手，尽可能控制去疫情，能够使我们社会回归正常的生活。
Dr. Zhu, please translate.
Oh yeah, so Dr. Xing is wrapping up. He said he's really grateful and for your attention, and then he wish you all well. Protect yourself. Stay healthy, and then hope the pandemic will be under control or contained soon, and we can go back to our normal life.
Okay, this is Tom Gong from Wuhan United. Thanks everyone for your time, and please remember to join Google Groups, Wuhan United-Medical. I send the email to everyone, because we will use that as a future communication to let you to send out the presentation. And also you please subscribe to our YouTube channel. We will post today's video on the YouTube. And also tell your friends and colleagues, we had some technical issue today. So unfortunately the YouTube streaming didn't happen. And we had, we didn't expect that many people registered, 3,000 people registered. We can only accommodate 1,000 on Zoom. We did plan on YouTube, and so unfortunately there's technical issue. It didn't happen. But anyway, so thanks everyone. We will set up the Google Groups. Hope we can continue using that Google Group to email each other, helping each other. Okay, thank you, bye-bye, everyone. We have people from 40 countries. Okay, thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
Welcome to visit Wuhan after the disease. OK。
Okay, great. Thank you.
Okay, Dr. Wu and Dr. Lee and Dr. He, can you come out, wave your hand? Dr. Lee and Dr. Wu.
You didn't put them on the screen. You
I
push.
know they have to unmute them and then say something.
Oh, on the so they have to do the video.
Yeah, Dr. Wu and Dr. Lee.
Hi, thank you everyone.
Thank you.
Yeah, hopefully it's helpful.
Yeah, it is. It is very
everyone.
important. Yeah.
李医生讲两句。 李医生。
Thank you for all attending. So hope everyone be safe and healthy.
Great. Thank you.
何医生。
Thank you.
Yeah.
Thank you. Yeah.
Thank you.
何医生。
我没有什么说了。
Okay.
谢谢。
Thank you everyone. Bye bye.
Bye bye.
Bye. Bye. Bye.
Bye.
Bye bye.